Good afternoon, everybody, and welcome to our program. We've got a special treat this afternoon. We have one of our moderators leading our discussion. I want to say DUI, but it's DEI, Diversity, Equity, and Inclusion. A few weeks ago, I was privileged to go with Dr. Wilkes to a meeting in Rancho Cucamonga and with a group that was graduating from medical school, and he presented a talk on DEI, and I was very impressed with it. And I didn't even throw any rotten eggs at him; he was so good. But Dr. Walks is a graduate of USC, also UCLA. He's a psychiatrist. He's former military, and he has been the medical director of the mental health program for the county of Los Angeles. More recently, he was the director of health for the city of Washington, D.C. He's met with the president of the United States and various Congress people and the Senate. And I think he also told me once he might have met with the Pope as well. But anyway, we're asking him to lead our discussion today. But another thing I want to mention, one unfortunate thing, one of my former professors who attended my oral defense of my PhD, Dr. Eugene Brunwald, famous cardiologist at Harvard, passed yesterday. I just want to recognize that he was a great man, an immigrant from Vienna, went to New York, graduated in NYC, and one of established the Department of Medicine at Brigham and Women's Hospital in Boston. So I just want to respectfully uh, pray for his soul. And we also have, I was very privileged this morning to see that one of my other heroes, Dr. John Arredondo, joined us, and he'll be commenting, I hope, and Dr. Richard Williams as well. So without further ado, I'd like to introduce the great Dr. Ivan Wilkes, my personal psychiatrist. Dr. Wilkes?
Thank you so much, Dr. Maxey. And I'm always honored to be in the company of all the great folks who join us for just a very important time. It's 1 hour a week and it's Black Health Trust. And hopefully today we can continue in the trend of giving useful information that can make a difference in the very important work that we do. And those of us that are not providers can get a better understanding of maybe how our providers can do right by us. I'm always excited when Dr. Richard Williams is on because he knows how to do this thing, how to do this information sharing thing, and it is just a privilege to be able to do that. So let me get started. Um, as Dr. Maxey said, I, I, I care about the fact that different people don't have the same level of opportunity for health based on a couple of things, and we will get into that. We spend, those of us who are providers of a sort, and of course, my personal psychiatrist, Dr. William Lawson, is on. Anytime I need a good psychiatrist, I don't look in the mirror, I look up Dr. Lawson and I call him. So we're going to talk about something that is really not taught in the medical school curriculum. We can name all the bones and trace all the nerves and explain complex cascades of immune responses and all of that. But there is a systemic and too often silent pathology that doesn't show up on MRIs and CT scans. And that is something that we refer to as health disparities. And sadly, in the United States, um, your zip code is often a better predictor of your life expectancy than anything in your genetic code. What do I mean by that? I mean that if we look at the most recent data, like I looked this up this month, April 2026. I don't think we get much more recent than that. Um, in our nation's capital, in the capital of the United States of America, um, the life expectancy for white residents in some areas is 87.4 years. For Black residents in some areas, it's about 70 years. Now, Dr. Maxey can check my math, but I think that's 17 years difference. That's long enough to start at the beginning and go all the way through high school. So, concrete example. If we look at DC is separated into different wards, like different sections of some other cities are. So we got 8 wards in DC. So let's compare Ward 7 and Ward 3 quickly. Because they have about the same number of people in them, right? So if we look at Ward 7, you have a life expectancy overall in that ward in Washington, D.C. Washington, D.C. is not Los Angeles. It's not a huge spread out area. I grew up in LA. You can drive across DC in a lot less time than you can try to drive across Los Angeles. But in Ward 7, a part they call east of the river, east of the Anacostia River, life expectancy 73 years. Ward 3, west of the park, upper northwest, 87 years. Now, some other things that are different, okay? Poverty rate in Ward 7, 26%. Poverty rate in Ward 3, less than 7%. Unemployment rate in Ward 7, 19%. Unemployment rate in Ward 3, less than 3.5%. And we're always telling folks to eat healthy, right? Number of grocery stores in Ward 7, 3. Number of grocery stores in Ward 3, 15. Number of children in Ward 7. Well, let me just hit this. Children in Ward 7 have 20 to 25 times more asthma-related ER visits than children in Ward 3. I didn't say 20 to 25%. I said 20 to 25 times the number of asthma-related ER visits. So let me dig into a little bit about why, without celebrating the problem too much. I like folks to tell me the problem, but please come to me with something we can do about it. Don't just tell me how bad things are. So there are several reasons why 2 patients with maybe the same cellular makeup may have vastly different survival rates depending on where they live and how we as providers, clinicians, people that are trying to make folks stay healthy, what can we do about it? Let's look at a couple of different areas. We've talked a little bit about life expectancy, maternal and infant mortality. This is perhaps our greatest failure when we look across America. And we've talked on Black Health Trust about some really challenging individual histories. We've talked about the great American sprinter Tori Bowie and her challenge, dying alone at home in childbirth after winning gold medals for our country. Black infants are more than twice as likely to die as white infants. And even more staggering, pregnancy-related mortality rates are 3 times higher for Black women compared to white counterparts, even when accounting for income and education. And then we can look at the chronic disease burden. Black adults are 50% more likely to be diagnosed with diabetes and far more likely to develop high blood pressure at an earlier age in our country. So let me get to the why. Social determinants and their structural roots. Why do these gaps exist? We like to think it's about bad choices. Well, if you didn't keep eating those pork rinds all the time, you'd be fine. Well, no, it's not only about bad choices. Remember I talked about those grocery stores, how there were only 3 in one part of the city, and for the same number of folks, 15 in another part of the city. Economic stability and food insecurity is a huge issue. Hispanic and Black households are roughly twice as likely to experience food insecurity as white households. Now, I'm not talking about DC anymore. I'm talking about America now, okay? If your patient lives in a food desert with no access to fresh produce, recommending a low sodium diet for their hypertension isn't medical advice, it's an impossible demand. Environmental racism. Communities of color are disproportionately located near industrial zones with polluted air and water, leading to higher rates of asthma and respiratory illness. I don't know how many years it is, Dr. Maxey, we've been hearing about the bad water in Flint, Michigan. I bet we'd hear about bad water in Beverly Hills, California for about a day or two before they made sure that that wasn't something that folks were subjected to. It's just a fact of life. This is just we tolerate things in some areas that aren't tolerated in other areas. Then there's the immigrant paradox. We talk a lot about Black and brown folks and other people of color and the challenges they have here in America with health. But there's something called the immigrant paradox that I looked up. We see a phenomenon where recent Hispanic immigrants often have better health outcomes than white Americans, but these benefits diminish over time as they are exposed to U.S. social and economic stressors. A lot of folks come to this country from places where they eat organic food grown in the ground, and they eat a lot healthier than they do when they get here. And health status changes over time from being here. And then, of course, I don't want to miss the burden of history and medical mistrust. We can't ask for our patients' trust without acknowledging why it was lost. We continue to live in the shadow of the Tuskegee syphilis study, where Black men were intentionally left untreated for 40 years. It still looms over our clinics. We remember the forced sterilization of thousands of Indigenous and Black women under the eugenics programs that continued well into the late 20th century. Even today, studies show that medical students and residents often underestimate the pain of Black patients compared to white patients, leading to systemic undertreatment. This is not history, it's a current clinical reality that we must actively work to dismantle. We actually did a program on Black Health Trust about this issue of Black women and the undertreatment of pain. So it's not all bad news. It's not all impossible requests. There is the ability for us to go from theory to action. There are some best practices in health equity in real clinical settings. So understanding disparities, which we've been looking at for the last several minutes, is really the first step. Dismantling them is the second step. So in our future practices, we don't have to reinvent the wheel. We can just look and see if other folks are doing things that make sense, that maybe we can emulate, maybe we can expand. There are some proven frameworks that are already closing gaps in diverse communities. So one step, integrating social care into clinical care. We must stop treating social needs as being quote unquote extra clinical. So best practices now include systematic screening for social determinants of health at every visit. For case example, Northwest Permanente screens all patients for social drivers, and when a need is flagged, community health workers who are often from the same neighborhood as the patients step in to help co-create action plans and provide direct resource links. Another place where we look at connecting folks with resources in their neighborhood. Dr. Lawson and I have both been involved in the DC area with a program that includes physicians and other providers and pastors and other faith practitioners, faith leaders, to look at how we integrate all of those things into providing healthcare. Another innovative program is a program called Street Cred at Boston Medical Center that helps. This is really surprising to me. They help families file tax returns during pediatric visits, facilitating millions in refunds that families use for essentials like food and housing, directly impacting things like birth weights and maternal stress. Using data as a mirror for equity, another area. You can't fix what you don't measure. And I remember meeting someone years ago who said, what can't be measured can't be valued. there is this notion about, well, I think this and I think that. But when we begin to look at things in a more critical way and begin to actually document, if I don't measure what's going on now, we all know this as providers. If I don't establish a baseline, how can I have any sort of valid notion of change over time without being able to establish a baseline? So you cannot fix what you do not measure. Forward-thinking health systems now use equity dashboards to stratify clinical outcomes by race, ethnicity, and language. Case example, Kaiser Permanente used targeted data to identify a 5.3 gap in hypertension control among Black and white Medicare members. By implementing a focused improvement process, they reduced that disparity by 58% in less than a decade. Another case example, Novant Health used root cause analyses to discover why Black patients had higher pneumonia readmission rates. By redesigning the discharge and home visit process, they closed their readmission gap by 50% in just 1 year. Community-centered accessibility. Achieving equity means meeting patients where they are rather than waiting for them to navigate a fragmented system. When I was working as the health officer in DC, we had mobile health clinics. Other organizations like BayHealth used a concept called Clinic on Wheels. They use these RVs to bring private exam rooms and screenings directly to rural areas and neighborhoods with limited transportation. What a joy, not having to take 3 buses to be able to get into a room where someone can examine you and be able to help you with addressing your needs right there in your own community. These are the kinds of things that actually are going on that go beyond the ankle bone connected to the shin bone and the other stuff that we learn about how the body works. We can learn how neighborhoods and how communities work and meet people where they are. Another thing that's fascinating is to think about medical legal partnerships, integrating lawyers into the care team, allowing clinicians to address root causes of illness, such as landlords refusing to fix mold or other things that might be triggering a child's asthma. Wow. And then, of course, language and literacy, right? Language access. Equity is impossible without clear communication. Best practices require professional interpreter services, not just for diagnosis, but for every step of the patient journey, and the use of plain language principles that ensure patients can actually act on the health information they receive. This is an area that's near and dear to me. I did a 2-year fellowship in transcultural psychiatry, and this notion of being able to recognize and integrate the importance of a person's cultural background into all of the diagnosis, findings, and care decisions and planning and all of that. It's just huge. If people aren't really understanding you, what are you doing? You're really not helping them as much as you could and not helping them to help themselves as much as they could. And by the way, just because somebody's family member speaks English doesn't mean that I may not want my grandchild to be in the room with me and translating all of my personal medical information. I'm a man of a certain age. A lot of the stuff that doctors have to talk to me about, I'm not trying to have my granddaughter be involved in that conversation. So let's really think about how we can effectively and respectfully get information back and forth between provider and patient. So the practice of cultural humility. Instead of thinking so much about fixing patients, we can think about partnering with patients. I tell my patients all the time, I don't believe in doctor's orders. I believe in doctor's agreements. I can tell you whatever I want, but if you and I don't have an agreement that you're going to take this medicine or perform this behavior or do this thing, we're not going to get to where we both want to get to. Myself and my patient both want to get to a healthier status for that patient. So again, doctor's agreements, not doctor's orders. So prescribing with perspective. I like that. It just sounds like the right thing to do, right? So one of the questions to ask your patient before you leave that exam room, before you leave that patient interaction, Are there barriers in your life right now that make it hard to follow this plan? Because, we're smart people. We're going to have a plan for you. But it probably is reasonable for us to make sure that it's a plan that you can follow. So maybe if we look at things like trust in the community as a way of integrating and understanding of community, not just community resources, but community individuals and groups that can be part of a more comprehensive approach to patient care and health optimization. Recognize that community leaders, faith-based organizations, and neighborhood advocates really are valuable colleagues. They're not outside of the healthcare system. Well, they don't have to be. We can pull them in and share our credibility with them so that the patients can see them as viable resources as they go through trying to make their lives healthier places for themselves and their families. Um, so I want to go through something I call a health equity mental safety check. Okay. So before we see a patient, we can acknowledge our bias. You know, there's some things to me that seem ordinary and normal, and some things that don't seem ordinary and normal. Um, I used to live right off of on Middleton Place off of 39th and Western. Things happen differently there than happen over in Maryland where I live now. Okay. And so being able to acknowledge that. Remember at the beginning, we talked about all of the differences between Ward 7 and Ward 3 in Washington, D.C. If you grew up in Ward 3, you may want to take a minute to understand the people you're treating in Ward 7, and vice versa. If you grew up in Ward 7, maybe take a minute to understand the folks that don't come from your community. So acknowledge, I acknowledge my own bias. Am I making any assumptions about this patient's education level, health literacy, or potential adherence to my program? I already talked about the importance of a certified professional interpreter. That's the standard we should try to meet. Um, During the visit, am I screening for some social drivers that might be a problem? I already mentioned asking, are there things in your life right now? Expand that question a little bit. Are there things in your life right now, like work, like housing, like transportation, that may make it difficult for you to take care of your health? The pharmacy check. Do you have a pharmacy you can get to easily? Are you concerned about the cost of the medication? And one that I personally experienced with patients when I was practicing in Southern California is this challenge, especially with mental health patients, of I don't want people knowing my business. So if I call your prescription in to the pharmacy right down the street, does the person standing in line behind you, are they in your community, and how are they going to feel, and who are they going to tell about the fact that you're picking up an antidepressant or you're picking up an anti-anxiety medication? So the pharmacy check, making sure that the person has access to a pharmacy that fits for them, not just the nearest one. um, Nutrition realization. Instead of eat more vegetables, maybe we can say, do you have easy access to a grocery store with fresh produce? Or do you mostly shop at smaller corner stores in your community? These are questions that can help people tell you what it is that is happening with them and happening and accessible for them in their community before we just run off all the things they should do. I know we are well trained and we are really smart, and we do know that the fresh vegetables are the things that they should be eating. At the same time, they can tell us how hard it is to get those. And maybe if we know that, we can connect them with a local food bank or some other place. I was walking down Foothill Boulevard in Laverne in Southern California. This is several months ago, and there was a big food giveaway, and they had all of these bags of food with all this fresh produce in there and all of that. I don't know that everyone who needed to know that that food bank was open that day at that big church up on Foothill was a place where they could get produce. But maybe if the practitioners in the area knew, and they could tell them which bus would stop up there. They could tell them where to go get fresh vegetables, not just say you need to go and do this. So there's that. Um, Cultural humility. I can feel comfortable saying to someone, I know the medical side of this, but you know your life. What should I understand about your routine or your beliefs that will help us make a plan that works for you? I was talking with someone who ran a one of the Medicaid HMOs and said that for many people, trying to get to the doctor during the week is difficult, Monday through Friday, because they got to work, right? So some doctors are open on Saturday. Okay, that's great. But they reached out as an organization to a local community physician who was a Seventh-day Adventist doctor. They worship on Saturdays. And so that doctor was able to open his office on Sunday because he was Seventh-day Adventist. And so now you have a Sunday doctor's office that's open in the community where folks can go. That's huge. A lot of folks can't get to the doctor other days. Sunday works for them. But unless we ask that question and we know to reach out to the practitioners we're working with and say, hey, could you see people on Saturday, on Sunday, as opposed to Saturday or during the regular work week? We will never open that door for many people who would love to walk through that door on a Sunday. And then plain language. The only people I know that are really impressed with all the fancy medical words I learned were my mom and Dr. Maxey. They really like to hear all that. The rest of the folks, they want to know what I'm talking about. They want me to use plain language, not the high-tech medical jargon. And then there's something called teach back or talk back, where I can say to my patient, can you explain to me in your own words what it is that you think I just told you? Because many times I am just being super eloquent. Dr. Lawson will tell you I'm just the most eloquent Dr. Walks, but I'm not communicating to the person I'm trying to talk to because the words I'm using, maybe, I don't know, the grammar, syntax, whatever it is that makes me say what I say, they're not getting it. The other problem I personally have, I used to stutter really, really bad when I was a kid. The other kids laughed at me and it was all fun and games. Now I don't stutter too much. You know what I do? I talk real fast. And if I'm talking too fast and nobody is willing to ask me to slow down or to tell me I don't understand you, that's on me. I need to make sure that I'm telling my patients that I care, that they are hearing what I'm saying. And this whole thing about the talk back or teach back method is a way of making sure that people are understanding what we're asking them to do. Um, so all that's before the visit, during the visit, after the visit. What about kind of thinking back, doing some sort of an analysis of what's going on, asking myself, is our system frequently failing the patient? What is happening that is making them be readmitted sooner? What is happening that is making them not get exercise? Do they live in a safe neighborhood? I remember doing a PTSD study when I was in LA. I was doing my residency at UCLA, and we were out in the community talking to folks about post-traumatic stress disorder. The end of the story is we found that living in certain communities puts you at just as high a risk for PTSD as being in a combat environment as a member of the military. That should make everybody pause. We have communities where folks are trying to raise kids that are, case in point, met a woman, we knocked on the door, we were doing this neighborhood survey and asking things about, do your kids have a safe place to sleep? Basic standard question. Wasn't prepared for the answer. She had 2 young kids and she put them to sleep every night in the bathtub. Who does that? Because it's a cast iron bathtub and periodically bullets would come into the apartment where she lived because folks would want to shoot out the street light so they weren't under the streetlight doing whatever it is they wanted to do. When they shot at the streetlight, sometimes the bullets would miss the streetlight and come into her apartment. So she would wrap her kids up at night and put them to sleep in the cast iron bathtub. Who wants to live like that? And how many doctors would ask that question? You have to go to people's homes sometimes and go to people's communities sometimes to understand what their life is really like. So I can talk all day about how important it is to understand what people are dealing with and what people are living with and how they're living. It's huge, hugely important. Um, so uh, you want to close the loop. If you have an expanded care team or folks that you work with, um, did you provide a resource list for someone? Did you just tell them what was wrong and prescribe medicine, or did you try to help them understand what else they can do to get better? Um, then advocacy. I love advocacy. I love the fact that as a human being with a loud voice, I can advocate for the things I think are important. On May 14th at my church in Maryland, we are having a candidates forum where all the folks running for office are coming to the church, and we are going to have a town hall style meeting where we can listen to them and what they think is important and because they have some idea, and then we can talk with them as community members about the things that we want to see from them. We should, in addition to complaining about what our elected officials are doing, we need to be at community forums. We need to be telling people about running for office. We need to be advocating for the things that matter to us to the people who are running for office, and then hold them accountable when they get elected. So I promised Dr. Maxey that I wouldn't talk too much, but Dr. Maxey, I only got like 12 more pages of notes. But I'm kidding. It's only 8 pages of notes. Let me stop and let me see if there are questions or there are points that we want to dig into a little bit more. I happen to feel that this notion of health equity is is just hugely important. There are important things. I have a clear understanding of how important it is when Dr. Richard Williams takes out a stethoscope and listens to someone's heart, and then from there makes decisions about what to recommend for next steps and what they do. I think it is as important that in addition to listening to someone's heart and how it's beating, that we are listening to someone's life and how they're living. Keeping in mind, let me go way back to something I said very early on, what their previous experience has been. Everybody hasn't been to Dr. Maxey to be their primary care doc. They may have gone to some other folks who maybe didn't help them as much as they could have been helped. Everybody's psychiatrist wasn't Dr. William Lawson. And so maybe they have some feelings about mental health. But I tell patients, I say to them, just because you've been to one therapist and it was an awful experience, don't say to me that I tried therapy and it's bad. That's like saying you tried on one pair of shoes and all shoes are bad. We are all different humans with different skills. Black Health Trust is here so that we can try to support each other in being better at the ridiculously important work that we do. We're working with other humans, trying to make them feel better and live better lives. I don't know what's more important than that, right? So if we aren't always trying to do that better, then we should. We just should. We should always try to do better at that. All right, Dr. Maxey, I'm done, man.
Thank you very much, Dr. Wells. That was a wonderful talk. And I'd like to ask the first question, but I'm going to ask my teacher, Dr. Richard Williams, if he would answer the first item. Dr. Richard Williams, can you be unmuted?
Dr. Williams is still muted. There we go.
Can you unmute that?
Hello, everyone. Can you hear me?
Yes, sir.
First of all, I'd like to congratulate Dr. Walks on those stirring remarks that he made. That was an absolutely wonderful compendium of information that he delivered, outlining essentially where we are and what we're facing in regards to healthcare disparities, uh, health inequities, and social determinants of health. So I congratulate him on that. I also want to make sure that everybody recognizes the fact that we are celebrating National Minority Health Month this month, April. And this is something that was begun as National Negro Health Week by Booker T. Washington in 1915. And so it's over 100 years old. It has evolved through the years and so forth. But one wonders really what its meaning is and what its impact has been. I won't try to detail all of that, but I would like to make some particular remarks if I'm permitted to do that for a very short period of time. Um, I have some difficulty with how we're approaching this issue of health equity. First of all, we need to understand what health equity means, what its definition is. Health equity is a term that has evolved through the years, starting with things considering cultural incompetence and cultural humility, also healthcare disparities, and now we're dealing with and also health inequality, and now we're dealing with health equity. The reason that we call it health equity rather than inequality, health equality, is because of the fact that they're not the same. When we talk about equality, we're talking about giving everybody an equal chance to achieve success in health care and improve their health status. But that's not the same as equity. Equity means not only giving everybody a fair chance, the same chance, and bringing everybody up to the same standard, but it means also giving those who are most impoverished, most impugned, an extra boost that is needed to get to the point that they need to get to. And that is a huge difference because that is exactly what underprivileged people or URM are being denied, that ability to get that extra boost. Now, we can talk all day and all night about all of the different things that are happening to us and how we should address those particular problems, but it's not going to move the envelope, so to speak, not going to push the envelope unless we address the underlying fundamental issues that are driving health inequities. And those include things that Dr. Waltz touched on regarding education and healthcare delivery, et cetera, all of those things that we all know too well that are insufficient in communities of color. What we need to do, I think, is to recognize the fact that we are being blindsided as we address these particular individual problems that many people face while we're trying to bring some sense to these problems that are affecting us individually. There are some fundamental changes that are going on as we speak and as we sleep that we need to address. And just to give you one example, Dr. Walks touched on the importance of data and what all of that means regarding health equity. Did you know that there are changes that are occurring now in regards to how data is used and developed and utilized to define who we are, for instance. there is a committee called the Office of an agency called the Office of Management and Budget, which has been defining who races and ethnicities are for several years. And they have said and dictated that there are certain categories which are to be officially recognized, such as Blacks or African Americans as one race, and whites or Caucasians as another, and then as an ethnic group, Hispanics or Latino or Latinx, etc. And to the extent that they define those categories, that is the extent to which monies will be deployed, if they are deployed, to treat illnesses and diseases that affect those particular populations. So it is important as to who is doing the defining and defining the data. There is a committee called the Data Equity Coalition, which is run by attorney Courtney Lang. You need to look into this. If you don't know who she is, you need to find out, because she's a bad sister who is intent on making sure that the data that is being developed by the federal government to define who we are and how we should be handled is something that is appropriate, and that it doesn't impugn us, but actually helps us. So that's one thing.
Can I ask you a question, Dr. Williams?
Yes, sir.
What is the best defense about this DEI that we need to do as a community?
About DEI?
Yes.
Well, I was going to speak on that, but let me talk on that real quickly. DEI, that is diversity, equity, and inclusion, is a moniker that was placed on a drive for equity a few years ago. To make a long story short, it's something that came under attack during the Trump administration, and under big attack, to the extent that the federal government warned, actually cut funds to agencies and organizations that were being funded by the federal government if they had any DEI components within them. And I have an article here that is from JAMA, which indicates that in May of 2025, the U.S. Department of Health and Human Services issued guidance warning that all federally funded medical schools should face investigation, for instance, if they use race in admissions or hiring, or require diversity statements regarding race and that type of thing. That's just one example of what is being done. So
let me get back to Dr. Walsh to comment on this too, and then there's several people I want to get into.
Okay, can I just finish though? I got a very important point that I want to try to make. I'm not going to take too much more time.
Okay.
Okay. I have one other thing that I want everybody to keep in mind and look out for. There's something called 340B. It's a statute, a federal statute. I talked about things that are blindsiding us now. That's something that was written into law in 1992. People don't know what it is, but it was a law intent on using federal funds to decrease drug costs that underprivileged people would face by paying hospitals money to decrease the cost of medicine that is charged to underprivileged people, especially in DSH hospitals, disproportionate share hospitals. That may not sound important, but it is, because those cost savings were supposed to be passed on to the poor people that it was supposed to benefit. Fast forward, and to finish my statement on that, those funds are not being used for that purpose. They're being used to enrich the hospitals. Poor people are not getting that money, and as a result, the drug prices that they're paying are higher than they would be if they were not in the 340B program. So we need to do something to address that. And I just want to put out something that is very, very pertinent to what we can do. There's a group called the National um, uh, hmm, the National Coalition of Consumers, National Consumers Coalition. You can look it up. They are trying to get as much information as they can on people who are being harmed by the 340B statute so that we can do something to address that and really benefit people so that they can get their drugs at cost less than $13,000 or $14,000 copay per year, which is ridiculous. That's
Thank,
what's harming us. Thank you.
okay, Dr. Walks.
I always love uh, Dr. Williams' input because, Dr. Williams is able to really hone in on the things that we can do. I said when I started talking, I don't like just celebrating the problem. And Dr. Williams is talking to us about we should know about this person who's doing something. We should know about this person who is doing something. We should get our own information. When we allow other people to just tell us stuff and we don't look it up. I remember when I was in DC, somebody told me, health isn't really so bad over in Ward 8 east of the river because they have a lower cancer rate than Ward 3. And after I thought about it for a minute, I said, wait a minute. Ward 8 is the youngest ward in DC. And so cancer, though it does impact children, cancer tends to be very impactful for older communities, which is the folks in Ward 3. So if you're telling me that because the cancer rate is lower in Ward 8 than it is in Ward 3, and I'm believing you, I might say, because they don't need as many resources. No, they're just younger. They're going to die sooner. They're going to get cancer, but don't just try to bamboozle me with some data. And that's why I love listening to Dr. Williams, because Dr. Williams will do the reading, do the research, break it down, and find a way to apply it. And I think all of us have to be willing to take the extra time. You don't just pull up a JAMA article if you're not reading JAMA. You have to be able to get into the resources that are available and then be willing to teach. And then the last thing I'll say about what Dr. Williams said is I mentioned advocacy earlier. Advocacy. We've got to be willing to talk to our elected officials. They're willing to talk to us. They think most of us are doctors and we can contribute to their campaigns. They'll talk to us. But what do we say when we write that check?
Dr. Walks, before we get to our other co-moderators, Dr. Lawson, I don't know if Dr. Neighbor Stevens is on yet, but
No, she's not.
I want to see if you recognize Dr. John Arredondo. I think he's a comment he might want to make. Is Dr. John Arredondo still on?
He's still on. He's trying to get unmuted.
I might be, yes, thank you. So you just asked me to make a comment. I was enjoying the report from our two chiefs here. Dr. Walks covered a lot of things. I would like to give one example just to show that if we do some of the things that he said, we can get results. Because in the final analysis, we shouldn't be giving prizes to people predicting the rain, only people who build an ark. And what he was just telling was how to build an ark.
Excellent, excellent.
We enrolled a group of patients, all on Medicaid. We dared to help them think and feel different. This is out of the blue, Dr. Maxey, but it's a fact. By giving them a different color Medicaid card. Government green. We had a beautiful rose. We even thought of getting the Tennessee government to laminate it. We thought that would be a step too far because we were negotiating with them to put on an unconventional way of preventing disease, being behaviorally oriented, and focusing on family care. We were just family physicians. The outline, the three bottom line results of what I'm going to say, the rest of it is preamble, but only because of what Dr. Walk said. He referenced asthma. He referenced kids and kind of some other stuff, advocacy. Well, we had, and we looked at the average number of hospital visits for each of those patients that enrolled in our new practice in the poorest part of town, 5 physicians trying to make up 2 full-time equivalents. We did that. After 2 months of practice, we extended our 9 to 5 hour practice to 8 to 5, plus you could make an appointment as late as 7 o'clock on Tuesdays. We all were going to get out at 8. We did. This was not walk-in, appointment. You could make it as late as the day before, if we had the slot, sometimes the morning of, before 8, before 9 or 10. But people picked up on that day before, just like they picked up on the fact that there was a doctor in the neighborhood. There'd never been a doctor in this hood, which was 4 blocks from the largest public housing project in Nashville, Tennessee. Just under 7,000 people there when everybody was for Christmas.
Okay,
So the people were enrolled rather quickly. We went out and knocked on doors on Saturday morning for about 5 Saturdays, August, September. We started to practice in September. We had the official opening in October. We had city, state officials there. We were somewhat connected through the community and through our own efforts. But we began to count officially from 1 January through the next year, December 31, 365 days. This was 1983. We looked at the number of people going to the nearest hospital emergency room. And that was our proxy for health status. That was our proxy for health equity. That was our proxy, lousy proxy, but it was the only one available.
so Dr. Arizona, we're almost at the top of our hour.
Yeah, let me make the bottom line. 1 year, the percentage of people, the number of people going to that hospital emergency room for asthma, Dr. Walks, and we decided to divide it and include people under 21, quote unquote kids. Adults have a little asthma too, but Medicaid serves kids more than adults. Again, looking at proxies for the real deal. What is the status? During that year, the number of visits to the emergency room went down by 94%.
Wow. Wow.
Now, let me tell you something else. The number of hospital days used by that hospital, public hospital, enrolled more Medicaid patients in Nashville than any other, including the Black Hospital. So, and it was close to them, just a mile and a half or so away. So it was easy for them to go to the public hospital. And that's where they lived. The number of bed days used went down by 92%.
Wow.
So
Wow.
not just in affecting the visits to the emergency room. Now, the visits to the emergency room could be looked at as a proxy for visits to the doctor. If that doctor was otherwise okay, maybe a decent average, not below average. Okay, is doctor doing some of the things that Dr. Walks mentioned, not all, but some. By either January, mid or end of January, we extended our practice hours to 7 o'clock on Thursdays.
We just got a couple more minutes.
And by April or May, before the halfway point, we had Saturday morning hours. Saturday morning hours, again, were by appointment of our patients. But all the other late hours could be appointment by anybody. As long as
Dr. Arizona, we're almost out of time. So
Dr. Maxey, what he's talking about can be done. That's all I want to say.
that's great. So
Well said. Well
top of
said.
hour. Let's ask our co-moderator, Dr. Lawson, for final comments.
I just want to quickly note that Dr. Walks mentioned the importance of the kind of activities that's happening in our environment and contribute to many of our physical problems. And one note that the consequence often are mental health problems that are ignored, often not measured, but clearly contributors. Now we're finding all the way from cardiovascular risk all the way to Alzheimer's disease. Is not in many of our clinics. We found that half the people in our clinics had major depression or post-traumatic stress disorder, the kind that our veterans face. We have screening instruments for this. Many times these conditions are not treated and are ignored, and as a result, these health disparities persist.
Thank you very much. Dr. Walsh, this is a wonderful talk today. We're going to do this again. Have final comments to you?
First of all, I would like to thank my co-presenter, Dr. Williams, because Dr. Williams always makes everything I do better. He makes me sound smarter. And I appreciate Dr. Williams really leaning into this, because the thing that Dr. Williams brings is significant and profound credibility. And when Dr. Williams says something is important, people will listen. And I think whatever credibility any of us have, we should bring it to this issue. We should bring it to the issue. And you know, listening is a wonderful thing to do. Dr. Williams said something that was really, 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 really key when he talked about equity needing to involve more for the people who need more than for every. It's not just equal everything. It is making sure the people who need more get the more that they need, so that at the end of the day, we don't have life expectancy disparities. We don't have asthma emergency room visit disparities. We don't have, we should never be able to make a 94% reduction in emergency room visits ever again. We should never be able to do that. The fact that we can do that is just, it's just awful. So I appreciate that being shared, because yes, we can make a difference if we pay attention to what's going on around us, if we let our patients educate us as much as we try to educate them. We can find those opportunities to lower bad stuff by 94% and lower bad stuff by 92% and raise life expectancy, so that at the end of the day, they're equal. If I'm a human and you're a human, why can't we live the same length of time? Why can't we do that? Why can't we have access to things that make all of our lives more rich? I got 3 words for you. I got empathy, compassion, and advocacy. Thanks, Dr. Maxey. I'm done.
Thank you very much, Dr. Walsh. I'm going to ask you to agree to do this again, like the president said, in the next 30 days, so we can continue this very important topic. I appreciate you doing that. And I'd like to comment that in addition to health equity, is what we need, which is we want everybody to have the fair chance at the best health they can get and whatever they need to get it. But there's also something called optimum health. And I think we need to look at optimum health, obtaining not just being equal with other people, but the best health we can possibly get. That's going to require precision medicine. I want to add that to the next session. Thank you so much, Dr. Walsh, for your excellent talk. Dr. Lawson for being with us, Dr. Arredondo, and my teacher, Dr. Richard Allen Williams. And thank you and thank you, Simon, for your help. Have a great, great afternoon.
Thanks, everyone. Good day.
Again.